Welcome, everyone, and thank you for joining our session. We'd like to thank the organizers of World Day of the Critical Lung for an excellent day of education, and also thank the Society of Critical Care Medicine for organizing this session this evening. Advances in early detection and management have led to significant increase in the survival rates of cancer patients. As a result, an increasing number of patients with cancer are requiring admissions to the intensive care unit for cancer-related complications or treatment-associated side effects. In session 9, there will be 3 speakers addressing short and long-term outcomes of oncology patients in the intensive care unit. Our first speaker will be Dr. Stuti Akella, who will discuss hematologic emergencies. Dr. Akella is a clinical assistant professor of medicine in the Department of Pulmonary and Critical Care at the University of South Florida and Tampa General Hospital in Tampa, Florida. Our second speaker will be Dr. Stephen Pastorius, who will explore treatment toxicities. Dr. Pastorius specializes in critical care medicine and is the professor of medicine and clinical anesthesiology at Weill Cornell Medical Center, Medical College in New York City, New York. And our final speaker is Dr. Sandy Kumar, who will reveal evidence-based practice challenges in oncologic critical care. Dr. Kumar is a critical care physician at the Cleveland Clinic in Cleveland, Ohio. Dr. Kumar has expertise in medical, surgical, cardiac, and trauma critical care settings. I'd like to welcome our first presenter, Dr. Akella.
Good evening, everyone. My talk is going to be focused on ICU hematologic emergencies, advances, and strategies. I'm here, an academic intensivist at the University of South Florida, and I have an interest in medical education, thrombosis and transfusion reactions in the ICU, ventilator weaning parameters, and oncological critical care. In today's session, we will identify and manage common hematologic malignancy-related emergencies, such as hyperleukocytosis, leukostasis, tumor lysis, and HLH. Furthermore, we'll also review the diagnostic criteria and management strategies for these conditions and use case-based studies to apply best practices in real scenarios. To provide everyone with a general overview of various hematologic emergencies, these 2 tables, this first one and the next one on the next slide, underline common emergencies that an intensivist would encounter in their practice. For example, one can see blast crisis in CML, and these patients can present with fatigue, weakness, visual changes, bone pain, fevers, and management would really involve broad-spectrum antibiotics, diuretics, leukapheresis, and cautious use of red blood cell transfusions. We will discuss atro differentiation in detail in some of the slides to come. Furthermore, in febrile neutropenia, patients have received chemotherapy and subsequently developed fevers, hypotension, respiratory insufficiency, and would need adequate antimicrobial coverage. In patients with thrombocytopenia, they can present with either bleeding or platelet counts less than 100. This can happen after chemo or in the setting of DIC. Usually, platelet transfusions are required in patients who are actively bleeding. In patients with DIC, they can present with thrombotic events, diffuse bleeding, and Trousseau syndrome, which is the presence of spontaneous, migratory, painful edema and thrombosis involving the superficial and deep veins in patients with cancer. Treatment is centered on supportive care. We will again discuss leukostasis and hyperleukocytosis in detail, and also HLH in further detail in the next slides to come. So moving on to our case-based studies, we have a 32-year-old male presenting with ear pain and a new right lump noticed near his neck and complaining of easy bruising over his legs, a weight loss of 20 pounds, and night sweats. As you can see, he's tachycardic, he's mildly hypotensive, he's saturating at 90% on room air, and his labs are significant for a white count of 240,000. He's anemic, he's thrombocytopenic, and he has a metabolic acidosis. So I'm sure looking at the answer choices, many of you would say all of the above for the question, what is this diagnosis? So unfortunately, his condition deteriorates and he actually ends up getting intubated. And this is his chest x-ray after intubation. So what would we be suspecting at this time? I would say that at this time, we have a hematologic emergency on our hand. This is hyperleukocytosis and leukostasis. Hyperleukocytosis usually happens with a WBC count greater than 100,000 with in the setting of leukemia. And then this usually develops when leukemic blasts aggregate in the microvasculature, causing tissue hypoxia, thrombosis, or DIC, resulting in organ dysfunction and failure. Furthermore, I think it's important for us to understand how some of these patients present to us. So they can present with altered sensorium, dyspnea, papilledema, and also pseudohypoxemia on the blood gas. And the reason they are pseudohypoxemic is because the WBC counts or WBC cells are hypermetabolic in the blood gas syringe, falsely lowering the PaO2 readings. Hence, as intensivists, it's important for us to use the SpO2 at the bedside as an indication for their oxygenation levels. So let's look at how we would achieve cytoreduction in these patients. There are three really main approaches to achieving cytoreduction. The first one being induction chemo, which is favored mostly unless the patient has renal insufficiency or severe electrolyte abnormalities. The second one is leukapheresis. This can be considered based on the patient's counts. And leukapheresis is highly center dependent, and understand that the data surrounding outcomes is fairly uniform between using definitive chemotherapy and leukapheresis. But while discussing either induction chemo or leukapheresis, hydroxyurea can be initiated in asymptomatic hyperleukocytosis. We also need to be very cognizant of holding transfusions in this patient population, since adding more red cells to their system can increase blood viscosity and stasis symptoms. So our patient, in this case scenario, gets a bone marrow biopsy, and after that, a presumptive diagnosis of AML is made. And then finally, he gets started on induction chemotherapy with cytarabine. But 6 hours later, we notice that on his basic metabolic panel, he has a hyperkalemia, a hyperphosphatemia, a hyperuricemia, and a hypocalcemia. We also have noted that he's having peaked T waves on his EKG. His ventilatory requirements also have progressively worsened. So in this case, we have tumor lysis syndrome. So tumor lysis syndrome is a rapid lysis of malignant cells, either spontaneously or after anti-neoplastic therapy, which releases toxic intracellular substances into the circulation. Risk factors usually include a high or large tumor burden, pre-existing AKI or CKD, the intensity of the chemo matters. If they are hypovolemic, that matters as well, and previous hypotension and other risk factors. There are both clinical and laboratory criteria for tumor lysis syndrome, but we really in clinical medicine at the bedside use the laboratory criteria. And in order to treat these patients, we start aggressive IV hydration. We also treat their hyperkalemia as quickly as possible. We maintain a urine output greater than 100 cc's an hour. And if we need to use loop diuretics to do that, we do that. And then we have to achieve a reduction in their uric acid levels with either allopurinol and or rasburicase. Allopurinol is a xanthine oxidase inhibitor, and rasburicase is a urate oxidase inhibitor. Apart from that, we also should remember that hemodialysis is an option for those patients who have refractory electrolyte abnormalities. So our patient actually does get treated for tumor lysis syndrome. He does actually very well with the IV hydration, the loop diuretics, rasburicase. He ends up getting transferred back to the medical floor. He's medically stable, hemodynamically stable over the next week, and eventually actually makes a full recovery and goes home with outpatient follow-up with our hem-onc specialists. Since we did touch a little bit about AML, let's talk briefly about retinoic acid syndrome. What is retinoic acid syndrome or atrodifferentiation syndrome? The pathophysiology of this condition really includes the release of interleukins, release of cathepsin G, and increased adhesion of blast cells. This causes fever, vascular permeability, endothelial damage, and a distributive shock-like picture. When you have either one of these features present, as you can see on the slide, fever, weight gain, dyspnea, pleural or pericardial effusions, even if one of these features is present, you need to start empiric treatment with dexamethasone 10 milligrams twice a day, and then hold the atra. But what is even more important is that we rule out mimickers of retinoic acid syndrome like infection, sepsis, pulmonary embolism, diffuse alveolar hemorrhage, congestive heart failure, and other causes of acute renal failure. Moving on to our second case, we have here a 72-year-old female with a history of systemic mastocytosis on outpatient fexofenadine, famotidine, cromolyn, and montelukast. She had a history of being diagnosed with atrial fibrillation in 2015, and she's had a history of PA arrest from anaphylaxis to lidocaine complicated by anoxic brain injury in 2015. But this time around, she presents to the hospital with abdominal pain, nausea, diarrhea, and melena. So on day 3 of admission, she has an episode of atrial fibrillation with rapid ventricular response, and she's treated with metoprolol, diltiazem, and digoxin. During that treatment, she develops a 7-second sinus pause, and at that time is transferred to the MICU. On day 4, GI performs a EGD, and subsequently they don't find any active source of bleeding. But the patient continues to get worse. On day 5 of hospital admission, at this point she's already in the ICU, she continues to have persistent fevers, persistent AFib despite rate control on amiodarone infusion, and an acute clinical decompensation marked by worsening respiratory failure with bilateral opacities in the lungs. We did send a very extensive ID allergy, immunology, and oncological workup. Again, if I were to ask all of you and poll this audience and ask what could this be, I'm sure all of us would say all of the above. So this is the day 5 laboratory workup that came back for this patient. Most of her workup, infectious workup, was negative except for her CMV PCR with over 1 million copies in her plasma. She had a high ferritin level, a high triglyceride level. She had anemia, thrombocytopenia, low fibrinogen levels, and a fairly high soluble IL-2 receptor level. She also had a bone marrow biopsy, which showed hemophagocytes, and her CAT scan of the abdomen pelvis showed splenomegaly to 13.5 cm. At this point, we started our patient on IV ganciclovir and dexamethasone. As the days went on in the ICU, on day 6, she received a dose of tocilizumab. On day 7, she had her first cycle of etoposide. And then on day 10, she received omalizumab per our allergy and immunology colleagues to decrease the risk of anaphylaxis in a patient who already had a history of systemic mastocytosis. So this is really HLH, which is a very challenging and obscure entity since there is an uncontrolled T cell and macrophage activation. Patients usually present with an undifferentiated clinical syndrome which looks like sepsis and septic shock, but they can have other end organ damage. They can have cytopenias, AKI, hepatitis, neurological symptoms, coagulopathies, and DIC. HLH is broadly categorized into primary, which is acquired or inherited, and secondary HLH, which is usually acquired. Secondary HLH, which is a life-threatening hyperinflammatory syndrome, can be seen with malignancies, aggressive lymphomas like NK cell lymphomas, hematopoietic stem cell transplant patients, immune checkpoint inhibitor therapy, severe infections like Epstein-Barr virus or cytomegalovirus infections, autoimmune diseases, and with a fraction of patients developing this after CAR T cell therapy. HLH has a very high degree of morbidity and mortality. So how do we establish a diagnosis of HLH? The establishment of this diagnosis happens when you satisfy 5 out of the 8 criteria shown here. In our patient, she had fever, she had a high ferritin, she had 2 cytopenias, 2 different lines. She had anemia and thrombocytopenia. She had splenomegaly, and she also had hemophagocytes in her bone marrow and a low fibrinogen level. Her IL-2 levels were also low. Her soluble IL-2 levels were also low. So we have now established a diagnosis of HLH in this patient. Now we move on to grading the severity. And one of the ways we grade severity is by using the 8 score, as shown here. This score is readily available on our devices here on our phones. So you can readily access and calculate the HATE score for these patients. Once we have calculated the HATE score, then we can consider this algorithm and see where the patient falls under the algorithm. In one of the cases, one other case that I had seen in the hospital, say the patient had fallen under the malignancy-associated HLH category, then we would go down the pathway of considering corticosteroids plus minus IVIG. And then we would potentially think about stem cell transplant, and then also think about salvage options as listed below in the algorithm here. This is a very nice review that was done by Dr. LaRosie's group back in 2019 that gives us a lot of clues and hints into how we can treat some of our patients with HLH. In our patient received steroids. She received a treatment for her CMV viremia, and she also received a dose of tocilizumab, and furthermore went on to receive etoposide as well. I guess at this point in the algorithm, it is important to note that we are having a multidisciplinary approach to involving hematologists, oncologists, our BMT and CAR T specialists in choosing medications that are critical to treat our patients at this point. So like I said, my patient actually ended up doing very well, even though she had a prolonged ICU stay, which involved other complications during her hospitalization. She actually did get discharged home at hospital day 62. So final take-home points for our lecture here would be that we looked at acute myelogenous leukemia patients that may commonly experience leukostasis, and these symptoms including dyspnea, respiratory distress, blurry vision, headache, confusion, and even stroke or intracranial hemorrhage. The treatment really consists of hydroxyurea, chemotherapy, and leukapheresis. In patients with tumor lysis syndrome, which is caused by a massive malignant cell breakdown, either following chemotherapy or spontaneously, we want to try and get them aggressive hydration, correction of their electrolyte abnormalities quickly. And finally, HLH is a life-threatening hyperinflammatory syndrome that can be seen with malignancies, severe infections, and autoimmune conditions. A multidisciplinary approach to diagnosing and treating this condition is very, very vital. Thank you.
Thank you very much, Dr. Akella. And I believe that we have Dr. Stephen Pastores up next.
Good evening, and thank you so much for the invitation to speak. I'm going to talk about the toxicities associated with novel therapies for cancer, primarily chimeric antigen receptor T-cell therapy and immune checkpoint inhibitors. These are my disclosures. So we're going to talk about the toxicities of CAR T-cell therapy, focusing largely on cytokine release syndrome and neurotoxicity. We'll talk about the immune-related adverse effects and outline the best practices for managing toxicities with these novel therapies. CAR T-cell therapy has revolutionized the care and treatment of many hematologic malignancies that were previously untreatable, despite already being in relapsed or refractory in treatment. So what are CAR T-cells? CAR T-cells are genetically engineered T-cells that basically act on tumor surface antigens to try to kill the cancer cells. They are made up of T-cell effective domain and a co-stimulatory domain that could be CD28 or 41BB, as well as the transmembrane domain, which anchors the CAR T-cell. And then you have an antigen recognition moiety that is comprised of two variable regions of an antibody that's joined by a linker, shown in the figure on the top. On the bottom left are the steps in the T-cell creation of the CAR T-cells and infusion into the patient. There are currently 6 FDA-approved CAR T-cell products worldwide. The first 4 that you see on the slide, Tisacel, Axicel, Brexucel, and Lysocel, target CD19, and they're indicated for adult patients with relapse or refractory large B-cell lymphoma, as well as follicular lymphoma, mantle cell lymphoma, and large B-cell lymphoma. The bottom 2, Ide-cel, Cilta-cel, which just got approved in the last 18 to 24 months, target BCMA, or B-cell maturation antigen, and these 2 CAR T-cell products are used for adult patients with relapse or refractory multiple myeloma. Shown here are the different toxicities associated with CAR T-cell therapy. They include infusion reactions, cytokine release syndrome or CRS, neurotoxicity that we now term immune effector cell associated neurotoxicity syndrome or ICANS, hemophagocytic lymphohistiocytosis, which we heard earlier from Dr. Akella, as well as prolonged cytopenias, B-cell aplasia, and hypogammaglobulinemia. I'm going to focus my talk largely on CRS and ICANS because these are the 2 most common toxicities that bring these patients into the ICU. Shown on the right are the timeline of these various CAR T-cell toxicities. If you look at the rates of CAR T-cell toxicities between the different CAR T-cell products, you can see in the middle of the slide that the CAR T-cell products that are against CD19 for the treatment of mantle cell lymphoma, such as Brexucell and Tisacel, are associated with the highest rates of grade 3 to 5 CRS and grade 3 to 5 ICANS. On the other hand, the newer products from multiple myeloma, which target BMCA, like Idacel and Cilta-cel, have the lowest rates of grade 3 to 5 CRS and grade 3 to 5 ICANS. Important to know that many of the deaths from cytokine release syndrome tend to be associated with respiratory failure, cardiac arrest, multi-organ failure, or development of secondary HLH. So let's talk briefly about cytokine release syndrome, or CRS. This is the most common adverse event from CAR T-cell therapy. It's a systemic inflammatory syndrome associated with fever, hypoxia, shock, and multi-organ dysfunction syndrome. It tends to be more common in patients with high malignancy disease burden, those who receive very large doses of CAR T cells, particularly those with CD28 versus 4-1BB as their co-stimulatory domain, patients who receive more intensive lymphodepleting chemotherapy, poor performance status, and those with low baseline platelets or elevated pretreatment inflammatory markers generally are more likely to develop CRS. The median time of onset is between 2 to 7 days and varies with the CAR T product and the malignancy that's being treated. The pathogenesis and pathophysiology of CRS first starts with the recognition of the target antigen when the CAR T cells are infused. They activate macrophages and monocytes to release a variety of pro-inflammatory mediators, such as IL-6, GM-CSF, interferon gamma, TNF, IL-1, and nitric oxide. These cytokines are responsible largely for vascular leakage, hypotension, cytokine and chemokine production, and all the different pathophysiologic mechanisms that we see in patients with severe CRS. CRS toxicities involve practically every organ from head to toe. The clinical syndrome is characterized by very high fevers, along with hypotension and hypoxia. Laboratory findings are not usually required for diagnosis. They tend to include neutropenia and low platelets, generally from the conditioning regimen prior to the CAR T-cell therapy. Elevations in C-reactive protein, inflammatory markers like IL-6 interferon gamma is found, as well as tumor lysis syndrome derangements. There is a modified endothelial stress index score, or the E6 score, which is equal to the LDH multiplied by the CRP over the platelets, which tends to predict patients who will develop severe CRS after CAR T-cell therapy. An E6 score values of less than 6.2 generally will identify patients that will have low risk for severe CRS. Since 2019, the grading of CAR T-cell CRS has been standardized by the American Society of Transplantation and Cellular Therapy. From grade 1 to 4, fever is universal across all grades. The two other criteria, as you can see on this table on the left, are hypotension and hypoxia. We tend to see patients at least with grade 2, certainly with grade 3 and 4 CRS. These are patients generally that will either have hypotension requiring one pressor if they're in grade 3 CRS, or multiple pressors if they're in grade 4 CRS. On the other hand, related to hypoxia, patients with grade 3 CRS will generally have hypoxia that requires either high-flow nasal cannula, face mask, or non-rebreather mask, or with grade 4 hypoxia will generally require positive pressure ventilation either by CPAP, BiPAP, or intubation. The treatment of CAR T CRS depends on the grade. We certainly will see patients with grade 2, 3, and 4 who will require ICU admission. We will give them supportive care. We will give them an IL-6 inhibitor like tocilizumab. You can see the doses there. And in patients who are high risk for severe CRS, corticosteroids are now being commonly used even as early as grade 2 and certainly with grade 3 and 4 CRS. In patients that are refractory to corticosteroids or require larger doses, pulse dose corticosteroids, 1 gram IV daily for 3 days, or siltuximab, which is an anti-IL-6 antibody, anakinra, an IL-1 receptor antagonist, as well as a JAK inhibitor in the form of ruxolitinib can also be used. Shifting over to the neurotoxicity from CAR T-cell therapy, this is generally related to endothelial cell activation, breakdown in blood barrier permeability, resulting in infiltration of cytokine and CAR T cells into the central nervous system. This typically occurs 3 to 10 days after CAR T cell infusion, and usually after the symptoms of CRS have already subsided. A patient with prior severe CRS will generally be the same patient that will tend to develop severe neurotoxicity. Other risk factors for neurotoxicity include, just like with CRS, high disease burden, the type of malignancy, more common in ALL than in lymphoma and multiple myeloma, increased intensity of the conditioning regimen and prolonged cytopenia, increased doses of CAR T cell, and those that receive CD28 co-stimulated CARs, such as Axicell and Brexucell, are generally the patients that are more likely susceptible to develop neurotoxicity following CAR T cell therapy. The clinical symptoms can range from word-finding difficulty to aphasia, motor weakness, obtundation, and even coma. Elevations in cytokines such as IL-6, interferon gamma, and TNF are frequently found, and non-specifically, you can have elevations in ferritin as well as CRP. Shown on the right are handwriting samples. As you can see in day 5, even though the mini-mental status exam of this particular patient that got CAR T was only slightly decreased, you can see the handwriting sample on day 5 with the presence of neurotoxicity was very difficult to decipher. A day later, after treatment, you can see a significant improvement in the same patient with her handwriting. The grading of ICANS or neurotoxicity is similarly standardized by the American Society of Transplantation and Cellular Therapy. There are 4 domains. We use the I score, which is the immune effector cell encephalopathy score. A 10 is a perfect score. But levels of consciousness, the presence of seizure, cerebral edema or increased ICP, and motor findings are also included as criteria. We tend to see patients with at least grade 3 or 4 neurotoxicity. These are patients who are either only awakening to tactile stimuli or may actually, frankly, unarousable. They may have a partial seizure with grade 3 neurotoxicity or be in status epilepticus if they are in grade 4. They can have focal edema on imaging with grade 3 or diffuse cerebral edema and signs of herniations with grade 4 neurotoxicity. And patients with grade 4 neurotoxicity will also have severe focal motor deficits. The management of ICANS generally is depending on the grade. Corticosteroids are the mainstay of treatment, and you can see the doses of dexamethasone that are used in increasing increments. In patients at very high risk for CRS and ICANS in particular, anakinra is considered early on, either sub-Q or more commonly given as an intravenous dose. For those with grade 4 ICANS, high-dose methylprednisolone is used, just like in what we do with patients with severe CRS. Supportive care in the ICU for these patients is very important. Many patients will require intubation and mechanical ventilation for airway protection. High-dose thiamine is given for neuroprotection. They need continuous EEG, diagnostic or therapeutic lumbar puncture if the opening pressure is high. We tend to target a serum sodium between 140 and 145 with 2% saline. We want to avoid CNS toxic antibiotics like carbapenems and cefepime, and we treat convulsive status epilepticus with a variety of anticonvulsant therapies. Management guidelines from the international societies are available. They have been published in the last couple of years, and I put this up here for your reference. In a multi-center study that we published along with our partners in the Oncological Critical Care Research Network, we look at the first 105 adult patients that were treated with Axicell and admitted into our ICUs for CRS or ICANS between 2017 and 2019. Nearly 3/4 of these patients had grade 3 to 4 toxicities, needing vasopressors, mechanical ventilation, and dialysis between 3 and 20% of the time. Notice that the organ support and ICU mortality rate was low. And what we did find was that those patients that received very high doses of steroids tended to have decreased overall and progression-free survival. We have expanded this study by looking at the last 6 years and found that the rate of admission for these types of patients have actually declined from 2018 to 2023. We are seeing patients getting this therapy who are older, higher severity of illness, more comorbidities, with higher need for invasive mechanical ventilation and vasopressors. However, ICU mortality remains relatively low, between 8% to 25%, and 30% or more of these deaths tend to be due to sepsis. The French have also published their own study earlier this year. Most of the results that they found were in patients receiving Axicel. They also found the ICU mortality was low at about 5%. And again, close to a third of these patients had actually bacterial infections. Moving over to immune checkpoint inhibitors, these drugs bind to immune checkpoint proteins to overcome tumor-mediated inhibition of T cell function. There are three targets: CTLA4, cytotoxic T lymphocyte-associated protein 4, PD1, programmed death 1, and PDL1, programmed death ligand 1. And you can see their mechanism of action on the figure on the left. There are currently about half a dozen FDA-approved immune checkpoint inhibitors that are used currently for lung cancer. Toxicities associated with this checkpoint inhibitors are now termed immune-related adverse events, or IRAEs. They generally peak within 6 weeks of administration of the checkpoint inhibitor. The CTLA inhibitors generally have more toxicity than the PD1, PDL1 inhibitors. Pneumonitis, again, is a relatively common adverse event with checkpoint inhibitors. You can have dyspnea, cough, chest pain, or new oxygen requirement. Median time is usually about 3 months from the time of administration of the checkpoint inhibitor and the development of pneumonitis. It's more common in patients who receive checkpoint inhibitors for non-small cell lung cancer, as well as renal cell carcinoma. It can manifest as radiation recall pneumonitis when the treatment is initiated years after the patient has also received radiotherapy. ICA-induced pneumonitis is a diagnosis of exclusion. You still need to exclude more common entities such as pulmonary embolism, pneumonia, CHF, COPD exacerbation, as well as malignant infiltration. Very interestingly, radiographic findings can range from ground glass opacities to peripheral or subpleural consolidation that can mimic a pattern of acute interstitial pneumonitis or even ARDS, as well as nonspecific interstitial pneumonitis and hypersensitivity pneumonitis on radiogram. What we found is that AIP and ARDS patterns tend to correlate with more severe pneumonitis and worse prognosis. On the other hand, patients who develop nonspecific interstitial pneumonitis or HP patterns radiologically after checkpoint inhibitor therapy tend to have lower grade pneumonitis and better prognosis. Again, similar to guidelines for CAR T-cell therapy, there are at least 4 international guidelines that have been published in the last few years, and I show them here for your reference. The management of pneumonitis, again, in general, depends on the grade. Patients with grade 2 or more are generally symptomatic. Corticosteroids are the mainstay of therapy for these patients. The checkpoint inhibitor is usually held. For those patients who develop very severe pneumonitis, there's permanent discontinuation of the checkpoint inhibitors. You need to exclude infection. So these patients, if they're otherwise stable to undergo bronchoscopy, you need to do a bronchoscopy with BAL to rule out an infection. Prednisone, methylprednisolone, can be used as corticosteroid therapy. You can see the doses there. And for those that are refractory to corticosteroids, infliximab, mycophenolate, IVIG, cyclophosphamide, or tocilizumab may also be used. More commonly, infliximab is usually our second agent in these patients. Other toxicities from checkpoint inhibitors include colitis, central and peripheral toxicities, including Guillain-Barré and neuromuscular disease, myocarditis, important to know because it can be fatal. Adrenal insufficiency, thyroid dysfunction can also occur. A variety of dermatological lesions can also occur, as well as renal abnormalities. Again, for all of these checkpoint inhibitor toxicities, steroids are the mainstay of treatment, and second agent that's used in refractory cases is still infliximab. So the key take-homes from this presentation are that toxicities with CAR T-cell therapies such as CRS and ICANS require very vigilant monitoring, aggressive supportive care in the ICU, the use of cytokine therapy, as well as corticosteroids. Despite grade 3 to 4 CRS or neurotoxicity, these are generally reversible, and ICU mortality tends to be low. With regards to checkpoint inhibitors, you need to remember pulmonary toxicity, pneumonitis, neurologic toxicities that can be central as well as peripheral, as well as cardiac toxicity in the form of myocarditis. The treatment remains corticosteroids. More importantly, is a requirement for a multidisciplinary approach that involves critical care doctors, oncologists, organ specialists, and use and adoption of standardized practice guidelines to ensure the best possible patient outcomes. Thank you again to the organizers and to SCCM for the invitation to speak at this symposium. Thank you.
Thank you so much, Dr. Pastores. Dr. Kumar, you're next.
Can you see my screen? Okay. Thank you so much for the opportunity. My name is Seni Kumar. Let me okay.
Doctor, can you put it in display settings?
Is this good?
Yeah. Yeah,
Okay.
thank you.
Yeah, so thank you. I'm a critical care physician at Cleveland Clinic. I have affiliation with NeoMed and Ohio University Heritage College of Osteopathic Medicine. I have no disclosures. So my main objectives will be describing about why the oncological ICU matters. What's the significance of having a dedicated oncological ICU? What are the evidence-based practices so far we know that works in oncological ICUs, and we'll take experiences from few of the ICUs that are standard of care in oncological critical care practice. And we'll discuss some of the ethical challenges that exist in taking care of this patient population, especially in the ICU. And so oncological ICU, it represents a diverse group of patients with complex needs. These are not a straightforward patients who just need BiPAP for the hypercapnic support or just need a high flow for pneumonia. Because they have so much underlying, from the oncological perspective going on. And, the number of cases are increasing each year. Like in the United States, over 1.8 million new cases, cancer cases are diagnosed each year, annually. And by the estimate, this year is going to be over 2 million. And by next year, it's going to be a little bit higher than that with the increased prevalence of cancer. About 10 to 20% of cancer patients require ICU during their treatment, which is, a decent number of patient population. And common diagnoses that we see, which include lung, breast, and GI cancers. And these patients often face multi-organ dysfunction and severe comorbidities. And understanding their need is important because, we can improve their outcomes. So what is the prevalence in ICU admissions? In patients who have advanced cancers who are admitted to the ICU, around 50 to 30% of those patients have advanced malignancies. And their ICU admissions have increased by 10% over the past decade in patients with malignancies. 70% of these admissions are due to complications of their cancer treatment. So knowing their oncological history and knowing their therapies is very important, as Dr. Pastoris talked about in the previous lecture about the CAR-T and immune checkpoint inhibitor, which have been evolving in the field of oncology. Median ICU length of stay for this patient population is around 5 to 7 days, and 50% of patients that are admitted to the ICU are over 65 years old. But this trend has a little bit changing in recent few years, because a lot of cancer cases are actually diagnosed these days in younger patient population. So in next 5-10 years, it is anticipated that this statistics may change. And age and comorbidities play significant role on their survival rate. What are the common complications? Respiratory failure is a common admission in the ICU in the patients having an underlying oncological history. Neurological complications are seen in 15 to 20% of cases. And hematological emergencies, as Dr. Akela talked in the first lecture, it can happen up to 25% of patient population. Sepsis, it's the big burden of ICU admission we see is second to sepsis, and is often related to due to their chemotherapy or immunocompromised state. And cardiac events can arise due to underlying conditions or treatment toxicity, and early recognition is important. Now, one of the things is, this patient population has psychological needs because they are already going through a life-changing diagnosis. And when they are admitted to the ICU, they have high level of anxiety and depression, which is very common in this patient population. And around 40% of patients experience significant psychological distress. And it is important for us to recognize that and provide the support and counseling to this patient population. And family involvement can help alleviate the anxiety in this in patients and their families. And palliative care plays an important role to improve the psychological outcomes, and awareness of these needs enhances the overall care strategies. Communication challenges, communication barriers, as we know, that exist in the regular, like a non-oncological patient and oncological patients, the same, sedation and cognitive impairment, Family members often serve as a key communicators and decision makers, and 60% of families report feeling unprepared for end of life discussions. So, having a strategized way of communication is important to improve the outcomes. And regular updates and clearly communication improve the family satisfaction. Involvement of social worker can enhance communication efforts, and understanding patient preferences is essential for personalized care. Family involvement of support plays a huge role especially in oncological patients admitted to the ICU, and 80% of families actually want to be involved in the care decision of their loved ones. And then support programs for families and enhance coping strategies, and creating communication strategies for the patient and their families. And it does strengthen, the holistic care being provided in the ICU. Now, evidence-based practices, we know the whole medicine has evolved, and evidence-based practices have changed the way we practice medicine. It is crucial for improving patient outcome in a complex patient population with high comorbidities, because as we discussed, around 15 to 30% of patients require ICU admission. So, that emphasize the need for specialized care, and adoption of protocols based on clinical trials and the guidelines enhances consistency in care delivery. And regular evaluation of outcomes using evidence-based practices fosters continuous quality improvement initiatives. So what are the certain examples? Like pain management. We know multimodal analgesia. We know the evidence shows that combining opiates versus with non-opiates reduces pain effectively. Up to 70% of patients, in ICU, they report severe pain. So having a strategy regarding pain control, continuous infusion protocols, utilization of continuous opioid infusion has been associated with the improved pain and the patient comfort. Adjuvant therapies like use of non-opiate agents like gabapentin, impact of palliative care consultation, early involvement of palliative care specialists has been shown to reduce pain scores by 30% within 48 hours of admission. And clinical guidelines, having adherence to the pain management guideline improve outcome. With 20% reduction in the pain-related complications. So I'll just give you an example. This is from MD Anderson Cancer Center in their protocol for management of inpatient pain, and you can see how strategized, because these are state-of-art oncological ICUs that practice, and you can see how strategized the pain control pathway is. You assess the pain, you assess the pain scores, you assess if the patients have been taking opiates or non-opiates, and then you strategize in that regard. And this is the evidence-based pattern of managing the pain in oncological patient population. Now, establishing rapid response protocol. This is from the Memorial Sloan Kettering Cancer Center. Now, we know having rapid response teams improve outcomes, and they have effect on the mortality depending upon which study we looked at. But having different sort of the rapid response protocols in place standardize the care and also provide the evidence-based practices. And you can see the evolution in state-of-art oncological care provided Sloan Kettering. In 2009 they have regarding ACS, in 2015 like emergency intubation, 2017 having sepsis alert, and interventional radiology like hemoptysis. We know the managing hemoptysis in cancer patient is very challenging because there's a lot of pathogenesis going on related to malignancy itself. And then 2018 with a stroke with pericardial tamponade, 2019 with spinal cord compression, where they involve the neurosurgery. Whenever there's a rapid response for spinal cord compression, it sends out a page to multiple different subspecialties, especially neurosurgery, if this patient is deemed to be a surgical candidate, if they have really a spinal cord compression or emergency going on. Acute limb ischemia, and 2020 with the involvement of the PER team. So you can see the evolution of rapid response protocol, which provide the evidence-based protocols to oncological cancer patients. Stroke pathway. Because one of the things that is challenging in this patient population is that about the anticoagulation. Do we anticoagulate? Because a lot of patients are thrombocytopenic, anemic, are bleeding going on, are admitted for some reason related to bleeding. So, the establishing a stroke pathway is very essential because it kind of standardizes the care. Like you can see in this algorithm that whenever you have concern for stroke, you involve the rapid response team. They go through, all the standard of care, having blood glucose, CT scan done within that time frame, having neurology involved, and the patient is deemed candidate for TPA or not TPA. Or does this patient needs to go to a neuro ICU or for neuro intervention based on the imaging? Now we know, SCCM has been very strong with involving like standardize the ABCDEF bundle, because we know how much it does impact our patient outcomes from the ICU. Implementing liberation bundles in during ICU rounding structures, or during when we talk about the patient with a nursing staff, or when we are talking with during the multidisciplinary ICU rounds. Assessing their pain, having this, sedation, vacation, breathing trials, choice of analgesia, implementing delirium protocols, mobility and exercise, and family engagement and empowerment. And they decrease the likelihood of hospital death within 7 days by 68%. That's a very decent number, 68%. They reduce the delirium and coma days by 25 to 50% and cut ICU readmissions in half. So, simplified by simply implementing the protocols actually help us, bring the good patient outcomes and bring the evidence-based practices into the critical care practice. Now, psychological support and palliative care integration, this is one of the key cornerstone, and especially taking care of oncological patients in the ICU is, as I made few points earlier on, psychological distress, or 40% of oncological ICU patient, experience anxiety and depression. There are different palliative care models which you can integrate, and early integration is very important because it can reduce the ICU length of stay by 25% of time. And family involvement is very crucial. Supportive therapies, psychological intervention, CBT has been shown to decrease anxiety by 30%, and having end-of-life discussion in a way that provide the family satisfaction and decrease feeling of hopelessness in both patient and families. Now, with all that, there are some ethical consideration that come into the practice. Like decision-making often involve complex ethical dilemmas. You always come across, sometimes someone doesn't have a good experience with the provider, or the families do not have a good experience. So you always come across certain sort of the ethical dilemmas and how to deal with it. Having goals of care discussion should be initiated early in the ICU step. Someone have stage 4 malignancy, they are in septic shock and 2-3 vasopressors, waiting for few days to have this discussion. Early discussion is important. And developing an ethical framework can guide the decision-making process in critical situation. And 30% of, it's a very decent number, 1 out of every 3rd patient, ICU cancer patient, experience futile care. Advanced care planning is vital for aligning treatment with patient values, and engaging ethics committees can assist in challenging cases, which can also, help us and help the families to dissolve the whole situation that revolves around. Now, in a way, caring of a cancer patient in the ICU or even on the medical floor, it's a continuum of care. Someone is diagnosed with a malignancy and they are admitted to the ICU. Identification and stabilization of underlying condition, either it's a HLH, either it's a septic shock, either it's a CRS, then having the interdisciplinary care planning, comprehensive care planning involving the patient oncologist who sees them as an outpatient, and allied healthcare professional, like nephrologists, or different subspecialties who are involved in the patient care. Symptom management is very important, helping with their pain, nausea, and then patient and family education, daily discussion with the updates that this is what is going on and how we are tailoring each and every symptom. And then when the patients are transitioned to ward or outpatient, then, creating that handoff system to have a continuity of treatment and follow up in the appropriate setting. If a patient doesn't have a good outcome, make sure that hospice follows up with them on, as an outpatient or a continuation on the ward. And it's a coordinated outpatient care, because patients we see in the ICU, when they go to the floor, we know a lot of patients are predisposed to have post-ICU syndrome, PICS. So having them a good follow-up with coordinated outpatient care can deliberate the situation and help the patient outcomes in general. Integrated oncology, palliative, and supportive care services in the outpatient settings. So key takeaway is, understanding the unique needs of oncological ICU patients enhances care quality. And, there's a continued research going on how we can identify the best practices to cope up, to implement the different practices, and multidisciplinary approach improve patient outcomes and family satisfaction. And education and training of ICU staff on oncological care is vital. And implementing palliative care principles in the ICU can optimize care, and future efforts should be on personalized and compassionate care model to provide the best care that we can do to our patients. Thank you. Thank you so much for the opportunity.
Thank you so much for those excellent presentations, Dr. Akella, Pastores, and Kumar. We do have a couple minutes for some questions. So the first question is for Dr. Kumar. How do you ensure that evidence-based guidelines are consistently applied in oncology critical care, especially in the rapidly evolving oncology specialty areas?
I think one of the ways is understanding what the state of care treatment is being provided, because if we know the standard of care, for example, for CRAs and HLH is XYZ, and our staff is all educated about all these protocols, and implementing those protocols and continuous education. I think one of the important thing is continuous education of the staff is very important, because with the change in the workflow, with the change in the nursing staff, with the change in the providers, having those protocols in place and having the continuous education models, I think can provide the best outcomes for this patient population.
Thank you.
Thank you.
The next question is for Dr. Pastores. As CAR T therapy becomes more common, are there any strategies that have been identified to help prevent the development of CRS or ICANS?
Yeah, excellent question. Clearly, the approach should be to try to prevent CRS and neurotoxicity from CAR T-cell therapy. Right now, we are trying to identify the patients with certain biomarkers that might be able to tell us. We already know the patients that are at risk for developing CRS and neurotoxicity, so we're trying to modify the ones that we can modify, identify the patients that are more likely to develop it. Just like when I presented earlier, there are inflammatory markers that can be elevated before treatment that will likely result in CRS after CAR T-cell. Low platelet count, patients that can be identified with high disease burden, the type of leukemia or lymphoma. So we can identify those patients at risk, and with some of the biomarkers that have been tested, we also know which patients are more likely to end up in the ICU. But at the end of the day, it's all going to still be a lot of preventive strategies, preventing infection, preventing common things that we see in the ICU, whether it's venous thromboembolism, aspiration pneumonia, stress ulcer prophylaxis. All of the things that we do for general ICU patients certainly apply to the patients that receive these novel therapies.
Thank you. Dr. Akella, HLH is often considered in the differential diagnosis in the ICU for oncology patients. Are there any one or two parameters that would make you more concerned or more suspicious of HLH over the other complications? Excuse me.
Great question. Thank you so much for that question. So I think that, like I pointed out, HLH is a mimicker of a sepsis and a septic shock-like picture. So a lot of these patients will present to us with symptoms of fevers, lethargy, dyspnea, which is shortness of breath. They will have potentially some laboratory abnormalities, but they can present with a host of different symptoms, including, like one of my patients that I presented, nausea, vomiting, abdominal pain. So really, I wouldn't say that there's one or two that would really clue us in. It's also the pace at which these patients actually tend to deteriorate in the ICU when they come in to see us to get treatment. They are very rapidly sick and require ICU level of care very quickly.
Thank you. This last question is actually for, sorry, we've got some in the chat. So in the chat we have, do you use any tools or scales to assess which patients need to be integrated into the palliative care team in the ICU? If not, how do you make those decisions?
Thank you. Thank you for the question. I think, few models that exist is that if someone have a stage 4 malignancy, should have a early palliative care consultation. If someone have a prolonged, a cancer with not good outcome, like very advanced malignancies and has failed different therapies and is in ICU with, suppose, for example, like septic shock or hypoxic respiratory failure on the ventilator, having a palliative care involvement early also helps improving, outcomes, help improving those discussion with the patient and families. So stage 4 malignancy, advanced malignancies, failed multiple therapies. These are the just certain examples, but each institution kind of have their own models. And one of the things is, if patient is being followed by palliative care as an outpatient, involving them in their stay in the hospital and the ICUs also helps a lot for the continuity of care. So these are the 3 or 4 things that we follow universally. And then it patient to patient specific. If someone is undiagnosed, newly diagnosed malignancy, then it depends upon, how the patient and families kind of feel to the new diagnosis and how the discussions are ongoing, and then depending upon the individual situation, you involve them. Thank you.
Thank you. I think we have 1 more minute to discuss oncology. Patients in the ICU can be extremely challenging to manage and to coordinate care. How do you foster effective collaboration between the myriad oncology specialists, the intensivists, and the other team members to address the unique challenges of these patients?
I think an important element is the daily discussions between the oncologist and the critical care specialist and any other organ specialist that's involved, be it infectious disease or nephrology, endocrine, whoever is consulting on the patient. But clearly establishing that relationship with the primary oncologist, either medical or surgical oncologist, with the critical care team to make sure that the daily goals of care discussions, the treatment plans are coordinated. And if things are not going the right way, trying to make sure that a multidisciplinary meeting is held to make sure the patient and the families are integrated into that. And again, if palliative care needs to be there, supportive care, chaplaincy, if things are not moving in the right direction and the patient is likely going to die, then those discussions can be fostered better if there are earlier goals of care discussions that are happening on a daily basis.
I think we're at time. Thank you all so much for the wonderful discussion.
Thank you so much.
Thank you. Have a good night. Take care.
Good night,
Bye-bye.
everyone.
Good night. Bye-bye.
Thank you.
Bye.